So I think the rationale that health plans would use for requiring any type of lab work or prior history to understand what treatments for IBD would be based off of multiple randomized controlled trials, which demonstrate the use of this lab improve the outcomes, whether that's defined as quicker acute flare control, when to titrate a drug, anything that can help improve the effectiveness or the safety of the drug. That would be the rationale that health plans would be using versus individual physician practices that prefer to do this way for all their patients, but another physician group prefers a different way. I think every health plan really does look at the total healthcare costs, and as the component of drug costs keeps increasing as that percent, whereas maybe 15 years ago it was only 10%, and now we're up to 17 to maybe 20% of drug cost is part of the total healthcare spend. It's really important that when we make a determination of which drug will be used for the management of any disease, it's not to look at just the cost of the drug, but the effect it's going to transcend into the total cost of care for that patient. So if we are going to increase the cost on the prescription side or on medication side, if it's even covered under the medical benefit, if that will then lead to lower hospitalizations or ED visits and those components that definitely have a much higher cost component that goes towards the total cost of care, I think most health plans, if not all, would definitely make that decision that we're going to increase our drug cost to decrease overall spend. I think where it gets a little tricky is when you have carve-outs for prescription drug plans. And so if the medical benefit carrier is one health plan and then a PBM is doing the prescription, now the two are not quite as tied. And I think that's when it gets a little tricky because the PBM has to make sure their prescription drug costs stay low because there's nothing it gets weighed against to say it led to a lower total healthcare cost directly. So I think that's where sometimes it can get a little confusing. That's an interesting question to have because this is not a straightforward black and white that this patient has this disease, therefore you are going to do now X, Y, Z. There's gradients of the disease. There's not just a simple mild, moderate, severe. There could also be further definitions within that of maybe how many bowel movements or other activities that are prohibited, and it takes a little bit more subjective look as well as the objective to go with that. So I think the challenge is when you have that highly variability in how a patient presents, to then define the severity level to see where they fit into the picture of where they're at with their treatment plan. I think that then gets into the concern of these drugs requiring a lot more prior authorizations versus just simple step therapies. So a step therapy would basically just say if the patient failed X, Y, Z in a prescription claim history, they can go ahead and get this drug, because we want to make sure for safety, especially if they're going to be using a biologic, that they're not at risk for infectious disease of some sort, such as TB, et cetera. That's not something we can step therapy. That's something we have to see that the test was done and that it is negative so that it's going to be safe for the patient to proceed to that. Or to understand where they are for their scoring to define them as moderate to severe. So whether it's a Mayo score that's used or a failure to demonstrate adequate response to certain drugs is easy as a step therapy, but then when you have to start putting different scales in there, or that the patient was in the hospital and had severe bout of number of stools and they really had a huge exacerbation, therefore now they have to move on to a biologic. Those aren't things that we can just create a simple step therapy. So I think one of the challenges in treating a highly variable disease such as IBD is also not really being able to just quickly simplify the review process or the prior authorization or the data that needs to be submitted with this form of a disease. So thinking through of what might make it a little easier for providers to know what would a payer look for and for payers to understand what providers have evaluated, I think it would be interesting to see how maybe a cost-value ratio IBD care pathway could be developed using the literature for what's the equal efficacy, safety, and then putting it in not just as mild, moderate, or severe, but then really further breaking it out into having the cost value, like this is $5, this is $2 signs, just having dollar signs to help kind of guide the physicians to understand, because a lot of patients have cost share involved, and so co-insurance, and it really helps make that become payer agnostic. But also the payers can have the evidence of which step they're going through, and having that, I think that could help further decrease the amount of back and forth. So initially there would be a prior auth, but there might not have to be as much back and forth because it's following kind of an agreed upon care pathway, understanding who's involved with the development of that to make sure there's no bias, make sure there's literature supporting each branch that it goes off to. And then it's not to say that's black and white, that that's the only way to treat, but it kind of gives a good overall guidance for everyone to kind of follow. And then with that, I think we could help provide a little bit more clarity on how to treat such a disease that has so much variability. So as we discussed earlier, with the variability with IBD presentation for patients, more than likely there would have to be some form of prior authorization. But to further reduce the amount of back and forth and discussions that would have to go, which I think is what really increases that administrative burden tremendously for both payers and providers, it is both ways, is if there could be more information, such as even just supportive document. Here's the lab test to show that the TB is clean, or here is the number of stools that they had in the last week, and versus just saying the patient failed steroids and therefore now I need to move on to a biologic. So the health plan does need to understand a little bit more of define failure for me. And so they're not looking for a book or anything, but they're just looking for those key bullets to understand how did you define failure, and to say that this patient tried X, Y, Z for 2 weeks, or did they just do 2 days and they came back to you, or what was the adequate time period for that test? And again, I think that's where those IBD care pathways would help as well. And this is a challenge. I can truly understand how a patient may feel confused, like this is a drug that's been working for me, I've been on it for years, and now just because I changed the health plan, I can't get it. The physicians are like, oh my gosh, you've done well with this, why do we have to re-justify? But the understanding that I'd like to pose out there for the providers is, as the payer is new to this patient, the insurance is new, the healthcare purchaser that made the decision to offer a new healthcare plan is also looking for, what are you doing to continuously manage this population? So a patient who's been doing well on a drug, the most important guidance I can give is when the physician submits, and they're, unfortunately they're going to have something submitted to say why this patient needs to be on drug X, even though drug Y is the formulary in this health plan and drug X was in the other formulary on the other health plan. If they can just quickly bullet, the patient had tried X and this many times, or 5 years ago, we've progressed to this, they've had absolutely no hospitalizations due to IBD in the last 3 years with this, or anything like that, that's very easy for the clinician to probably just quickly say off the top of their head of this is why I think you should stay on it. And that's literally what we need to see. But one idea that I've had of what can maybe on the provider side they can do to help themselves prevent more administrative burden, as patients do have to flip insurances, whether it's their healthcare purchaser or their own benefit design that's doing this. It would be really nice if in their EMR system they could have something that could just be dropped in for IBD, to just every time something's tried, it's just kind of not into a separate note, but just some other bullets that they could have to just pull in. Steroids tried in 2005 and failed, was this, had 3 hospitalizations while they were on drug X, moved on to drug Y. So then anytime the patient is being asked for information because they have to continue, the doctor doesn't have to redig, and it can just be there available quickly for them to print, because that's all that the insurance is really looking for. They just want that understanding of what was going on with them prior to them joining their health plan. And this is really important that it's payers and providers can coordinate, because it is an important collaboration for the patient. Both have the same intention, is the patient needs to receive their treatment, there is the correct treatment, the correct dose, the correct time for the correct length of time. And the best way for this to be coordinated is to have more transparent communication between the two, meaning sharing of that key information of when the therapy has to now proceed to more a biologic. And that's really where the payer probably gets more involved with having communications with the provider for IBD is, the patient's now proceeding to these drugs that do cost $4,000, $5,000, $6,000 a month. And when they get to that point, there's a lot of healthcare purchasers that are questioning, did my employee really need that? Is this the right time? Is this the right length of time? And so the discussions we've had prior to of that open communication, what are the key points that the provider can supply to the payer of why that patient needs to proceed to the biologic and why it's this specific biologic and this dose, and what's the intention for they're going to be monitored this way for this much length of time. Is there any step-down therapy option at all? Is there not? That would give so much more leverage for the payer in case a healthcare purchaser had questions as well, because when there's a self-insured employer, it's their money, and they have every right to question how their money is being spent, right? So this helps develop that partnership for the payer on behalf of the provider for the patient and vice versa.